welcome to ICU Fellowship Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil, and welcome back to yet another fellowship snippet. So we have discussed two snippets till now. So this is our third snippet. So let's start with the case scenario. As the duty locum intensivist, you have been called to urgently review a patient on the medical ward of a small hospital. The patient Jane, she's a 32-year-old female who has been admitted to the ward yesterday with a shortness of breath. She complains of shortness of breath on and off, and she has been recently started on the bronchodilator. A local GP registrar who was reviewing her earlier on the ward round noticed that Jane was struggling to breathe and working really hard. And then anesthetics who are present in the hospital decided to intubate this patient prior to your arrival. You arrive after this patient is intubated and you notice the sats are still in 85% and patient is hypotensive with a systolic blood pressure of 75 millimeters of mercury. So can you please outline your management in this situation?
So this is an emergency situation which requires simultaneous urgent evaluation and resuscitation to identify and treat the cause and contributors to Jane's deterioration. So my approach would be to activate the emergency response team if available in this hospital for extra personnel and rapidly assess whether this is an issue with the ETT, a peri-intubation event, or a deterioration in the patient's underlying pathology. So in terms of first, I'd need to call for help and allocate roles and to ensure the team is functioning well, ensure there's maximum oxygen delivered via the bag valve mask and that the resus and airway trolleys are present and that this patient has good intravenous access, and using small bottles of metaraminol to aim for a systolic blood pressure of 90 millimeters of mercury. So my initial priority is to confirm that the ETT is actually in the right position and not obstructed. And I would use end tidal CO2, bogging and misting of the tube and equal air entry, and also examine the end tidal CO2 trace. So if there's concerns that the tube is esophageal or obstructed, so remove the ETT, handbag with a Gadell and obtain emergency airway intubation, and then try an LMA if there's difficulties with hand ventilating, and aim re-intubation with the most experienced operator. If the endotracheal tube is in place and not obstructed, it's either a peri-intubation event or there's a deterioration in the patient's pathology. Potentially, given the stem, it might be asthma exacerbation. So I'd be assessing the patient, looking at her vital signs, whether the EtCO2 traces are obstructed, the chest wall movement and the compliance of her lungs, and looking for other like rash or circulatory changes, and a brief history from the staff surrounding the medications given and the intubation events. So was there adequate paralysis, the grade of intubation, whether there was any aspiration on induction, and Jane's history and progress on the ward, and doing investigations to help identify the cause. So bedside investigations looking at the ABG for the oxygenation and ventilation, an ECG looking for arrhythmias or any potential myocardial events, and a chest x-ray looking at things like pneumothorax collapse or consolidation. And the specific treatment will then depend on the findings. So if there was signs of dynamic hyperinflation, stop bagging, disconnect her and from the bag or the ventilator and allow adequate expiration. If it's hypervolemia contributing, there'd be a fluid bolus of crystalloid. Vasodilation is potential secondary to the induction agent. So I'd use metaraminol initially to aim to optimize her blood pressure. Anaphylaxis is also possible. So if there's signs of a rash or urticaria, using IM adrenaline, 0.5 milligrams, and then she might need an adrenaline infusion. If there's signs of pneumothorax, like a deviated trachea or hyperresonance on one side, decompress it with needle decompression, and then she'd need a formal chest drain. There are other potential causes like aspiration during intubation, which is generally needed. Like the treatment is aimed at optimizing the ventilation settings, but you might need a bronchoscopy. Worst in community-acquired pneumonia, decreased cardiac output or dysynchrony are also potential causes or contributors to her hypertension and hypoxia. So my evaluation would aim to assess for these causes and then specific management, specifically treat these causes. In terms of the logistics element as well, she's on the ward at the moment, so we'd need a ventilator and a monitor from ICU and aim to stabilize her or have her on an improving trajectory prior to transfer to ICU. And given that we're at a small hospital, depending on her trajectory and the resources available, consideration also needs to be taken about potential need for retrieval or transfer to a larger centre. But at this acute stage, it'd be aiming to try and treat this hypoxia and hypotension.
That's correct. So, as you're worried about a lot of differentials here, you managed to get a chest X-ray relatively quickly, and you ruled out endotracheal tube obstruction and confirmed the position of the endotracheal tube. But also, you ruled out pneumothorax or any other lung pathology such as consolidation. Now, her stats are improved to 92%, and you managed to transfer this patient safely to intensive care unit. And your bedside nurse has asked, what settings would you like to commence this patient on?
So my concern currently is still a severe asthma exacerbation, and my settings would aim to avoid dynamic hyperinflation, optimize Jane's oxygenation and ventilation, likely tolerating some degree of hypercapnia, and minimizing any ventilator-induced lung injury. So I personally use a volume control mode in these patients and aim for a plateau pressure less than 25 centimeters of water. I start with a PEEP of 0 while they're paralyzed and not triggering breaths, an IE ratio of 1 to 4, but assess the flow time and volume time waveforms to ensure that they return to baseline during expiration. Otherwise, I'd prolong the expiratory time or reduce the respiratory rate and make sure that there's a high flow rate of at least 60 to 80 litres a minute to reduce the inspiratory time. I start with a respiratory rate of 10, but this might change depending on serial reassessments. Start with a volume of 6 mils a kilogram, but decrease this if the plateau pressures are persistently above 25 centimetres of water. I begin with a FiO2 of 100% and then decrease this, titrating to a SATs of greater than 92%, and increase the peak inspiratory alarm pressure. So tolerate high peak pressures as long as the plateau pressure is less than 25, and make sure that she's on a humidified circuit.
That's correct. So you mentioned a very pertinent point there about the peak inspiratory pressure and allowing them to be high. And sometimes you have to go up to 60, 70, 80 centimeters of water as long as your plateau pressures are less than 25. One of the key thing or limiting factor to do that in our ventilators across all ICUs is most of the ventilators are on autoflow mode, especially in the volume control. And sometimes you have to change that autoflow to manual flow and then increase the flow rate to 80 or 90 liters per minute, because autoflow is set at 40 liters per minute and the ventilator won't be able to achieve the tidal volume. Once the peak pressure reach to 40, 50, the flow will be cut off. So just to keep in mind, if you're going to increase the peak inspiratory pressure alarms, you might have to change the patient from autoflow to manual flow on the ventilator settings.
Yeah, that's a good point. Like the I'm working at, we use Draeger ventilators, and the common mode is SIMV volume control, but it's not actually a volume control mode. It's because autoflow's on. So if you look at the flow waveforms and the pressure waveforms, they're actually a pressure control mode, but you can set a volume with it. So in order to ventilate with a pure volume control mode, you have to turn the autoflow off.
Yeah, so all ICUs now mostly they're switching to SIMV PRVC as the default mode, which is the pressure regulated volume control mode. And ventilating patient with asthma with the PRVC can be quite challenging. So yeah, so you need to switch to a pure volume control mode with a manual flow. Now you mentioned another important thing about starting with a 0 PEEP or ZIP. Can you please outline your rationale for ZIP versus low PEEP in patient with asthma?
Yeah, so the amount of PEEP to use in the intubated asthmatic patient isn't clear. It's still something we're being discussed. Traditionally, we use 0 PEEP, but now some people are starting to use low PEEP. And the reason for this is a small amount of external PEEP is thought to potentially decrease the end expiratory alveolar collapse, especially in patients who have very high alveolar pressures. And secondly, when patients are triggering the ventilator, a high intrinsic PEEP can make it difficult for the patients to initiate a breath as they need to overcome a large pressure differential. So adding external PEEP of about 60 to 80% of the intrinsic PEEP can help reduce this effort required to trigger the ventilator as it reduces this pressure differential. But this would only apply in the patients who aren't paralyzed, so who are triggering the ventilator or spontaneously breathing. Conversely, 0 PEEP, the rationale is that patients often are generating their own auto PEEP, so theoretically already have ability to splint some of the airways open. And then in that case, extrinsic PEEP may just contribute to dynamic hyperinflation. And in the fully sedated, mechanically ventilated patient who's not triggering their own breaths, they don't have this work of breathing required to overcome intrinsic PEEP. So adding extrinsic PEEP risks exacerbating dynamic hyperinflation. I think there's no right answer, but you just, whatever you do, you have to carefully monitor the patient for the effect and maybe try slowly increasing the PEEP and seeing if they're having signs of dynamic hyperinflation. And especially when they start to spontaneously ventilate, they will likely need some degree of PEEP.
Thanks, Marie. As you mentioned, it's not a very easy answer, and it depends on a lot of factors. So the first and foremost is how much plateau pressure is there already. If you're very close to 25, adding the PEEP is going to push your plateau pressure above 25. So that's one thing. But also how hypoxic patient is. If patient is really not very hypoxic and intrinsic PEEP is already at 8 or 10 centimeter of water, probably adding extrinsic PEEP is not going to be useful in that setting. So it really depends on individualized patient at the bedside, how their ventilator dynamics looks like. So rather than having this blanket approach of zero PEEP or low PEEP in each patient with asthma, I think you just need to be monitor, stand at the bedside, look at their ventilator parameters, look at their hemodynamics, look at their oxygenation status, and decide whether you can afford to add extrinsic PEEP or not at that point in time. But the situation is going to be dynamic. So that means you have to evaluate and reconsider your approach and adapt as you go, rather than having this fixed mindset of zero PEEP for all asthma patient for next 24, 48 hours kind of thing. I think that approach is not going to work. Also, one of the things that always come in discussion about asthma patient regarding their ventilation is which mode. Again, there is no right or wrong answer as to which mode you can ventilate patient with asthma, with volume control or pressure control. Obviously, the volume control has got more benefits over pressure control mode, but again, it's not been demonstrated any benefit in any studies. But one mode is going to be very harmful, and just being very mindful is APRV mode or the bi-level mode, where that mode is obviously set to inflate the lungs, and then that can be quite challenging for asthma patients. So just be mindful that which mode has got advantages and what are the disadvantages of each mode, and then choose the mode that you know the best, so that you know how to troubleshoot in case things start going in the other direction. So you mentioned about dynamic hyperinflation for a few times. So what is dynamic hyperinflation, and can you outline at least two methods to assess dynamic hyperinflation in an intubated asthmatic patient?
So dynamic hyperinflation is an increase in end expiratory lung volume due to incomplete expiratory emptying of the lungs in patients with airflow obstruction, such as asthma. So it's failure of the lung to return to its functional residual capacity or relaxed volume at the end of expiration. Two ways to measure it: an expiratory hold maneuver. So this is where we do an end expiratory hold. And so there's a pause where there's occlusion of the circuit at end of expiration. And this allows the alveolar pressure to equilibrate with the airway pressure. And this number minus any extrinsic PEEP that you've added is the intrinsic PEEP. This requires the patient to be sedated and paralyzed for an accurate measurement. And it's thought to often underestimate intrinsic PEEP, as dynamic airway closure prevents the alveoli with the highest pressure equilibrating with the circuit. The other method we can use is looking at the plateau pressures. So for this method, we measure with an inspiratory hold maneuver, and the pressure falls from the peak, which is the resistance plus the compliance, to the plateau, which is the static compliance pressure. And this is measured obviously at no flow, and therefore theoretically is equilibrated with alveolar pressure. But once again, for accurate measurement, the patient needs to be sedated and paralyzed, and the circuit should be complete and not have a significant leak. And as the lung volume increases in dynamic hyperinflation, the plateau pressure will also increase. So this is a way to evaluate and measure dynamic hyperinflation.
So let's move on to the management. You already have this patient sedated and paralyzed with appropriate ventilatory settings, and you tried all inhaled bronchodilators and IV steroids, but this patient fails to improve. What are the other treatment options that are available for this patient, and what are their mechanism of action?
So there are different treatments such as magnesium, intravenous, salbutamol, adrenaline, methylxanthines, ketamine, inhaled volatile agents, and finally extracorporeal support. So magnesium blocks calcium channels, and so in the smooth muscle cells of the airway, and it inhibits histamine release from mast cells and acetylcholine release from cholinergic nerve terminals. And this increases bronchodilation and decreases airway excitability. And it's also thought to have a membrane stabilizing effect in the atria, which might help attenuate the tachyarrhythmias that can result from beta agonist therapy. The interestingness, like I've put some in the show notes, just some comments about some of these treatments and some interesting things. But magnesium, interestingly, is recommended in a lot of guidelines, but there's actually a poor evidence base. And there's some links to some trials just in the show notes. Intravenous salbutamol is a beta-2 adrenoreceptor agonist. So it activates adenylyl cyclase, which increases cyclic AMP, activates protein kinase A, which inhibits phosphorylation of myosin and decreases intracellular calcium. And this causes bronchodilations. And the increased cyclic AMP also inhibits mast cell degranulation, which reduces some of those inflammatory mediators from being released. Adrenaline is also a beta-2 adrenoreceptor agonist, so it causes bronchodilation in the same way, but it also is an alpha adrenoreceptor agonist and causes vasoconstriction, which decreases airway edema and might improve your hemodynamics. It's generally not recommended by guidelines unless associated with anaphylaxis or in cases of severe life-threatening asthma. Then there's methylxanthines such as aminophylline and theophylline, which inhibit phosphodiesterase 3 and 4. And this is the enzyme responsible for breaking down cyclic AMP. So this once again causes increased cyclic AMP, which can cause bronchodilation. It also binds to adenosine A2B receptors, which blocks adenosine-mediated bronchoconstriction. This has a very narrow therapeutic range, and it's more used in the pediatric population compared to the adult population, as it requires monitoring of levels. It's less familiar. It's recommended by certain guidelines, sometimes like in Australia, especially in severe asthma cases. But actually, a lot of the guidelines from overseas do not recommend theophylline or aminophylline. Ketamine can be used. So this blocks the NMDA receptors, which prevents bronchoconstriction, and it inhibits catecholamine reuptake, which causes bronchodilation and inhibits vagal outflow and reduces calcium influx. There's, once again, minimal evidence base, but we do use it a lot in severe asthma, and it's also useful as an induction agent if you do have to intubate the severe asthma patient. And then there's inhaled volatile agents such as desflurane or sevoflurane, which block voltage-gated calcium channels and reduce calcium stores in the sarcoplasmic reticulum, causing smooth muscle relaxation. I have seen this done before in cases of severe asthma, but it does have its own logistic issues because you need an anaesthetic machine and generally an anaesthetic nurse. And there's difficulties with scavenging within the ICU. You do have all the side effects from these inhaled volatile agents, which are often hemodynamic, such as hypotension and myocardial depression. And then finally, if in severe asthma cases, you can use extracorporeal support, such as VV ECMO or extracorporeal CO2 removal. And this is like any extracorporeal support. The venous blood is extracted, pumped through an artificial membrane lung. So in the case of VV ECMO, it's oxygenated and then returned to the patient, and the CO2 is cleared by diffusion as a flowing or sweep gas containing no CO2 runs along the other side of the membrane, resulting in a diffusion gradient of the membrane. In the extracorporeal CO2 removal, there's no significant oxygenation, but it allows for smaller cannulas and lower blood flow rate. But as with any extracorporeal support, these modalities require specialized centers and expertise, but it does allow for the minimization of ventilator-induced lung injury while waiting for the bronchospasm to improve, and is thus maybe a bridge to recovery.
Thanks, Maddie. These treatment options are often asked, and candidates often lack the understanding of mechanism of action of these different agents. So I think this is a very important question to consider. Let's say patient has received a lot of nebulized salbutamol. What are the signs of salbutamol toxicity?
So there are signs on exam and there are investigative findings. So in exam, the patient is tremulous, tachypneic, and can be agitated, especially in the pediatric population. Investigative findings are hypokalemia, hyperglycemia, and a raised lactate with a metabolic acidosis, which is usually a lactic acidosis. It can be, obviously, a lot of these findings can be present just in the patient with severe asthma. So it can be hard to differentiate from salbutamol toxicity and worsening asthma severity. But it is something to think about in the patient who is having either salbutamol infusion or back-to-back nebs for a prolonged period of time.
Thanks, Maddie. So that's the end of our today's snippet. We'll be back with another snippet in week's time. Till then, goodbye and have a nice time.
Thanks for listening and see you next time.